Good morning and welcome everyone, and thank you for joining us for today's webinar. My name's Debbie Turner and I'm a Senior Medical Liaison at City Fertility, and we're global leaders in fertility and IVF care. Some of our most frequently asked questions are going to be answered today about female infertility, and this webinar is going to be presented by Dr. Lisa Harris. And we hope you feel free to ask any questions during the presentation by typing them into the Q&A box. The Q&A box is in your panel, on the control panel on your right-hand side if you're on a desktop screen, but if you're on a mobile phone, you'll find it down the bottom on the left-hand corner. So please remember this session is completely confidential. We don't want you putting questions in chat. We want you to use the Q&A box, and that way we won't be able to see who's asking the questions. And also, while you're asking the questions, please make sure you don't put anything in there that might identify who you are. So also, for those of you who are joining us via your mobile phone, please make sure you pop it on mute, and also maybe even put it on Do Not Disturb, because if you get a phone call during the process, it will actually kick you out of the webinar and you're going to have to come back in. That's easy enough done because you can go back in via email and press on the link again, and it'll just bring you back into where we are up to now. So our agenda today is going to include things like what is female infertility, the signs and symptoms, the causes of female infertility, common diagnoses, fertility treatment options, and when to seek fertility help. After today's session, we're going to send you a free guide to tips to boost fertility, and we'll also send you an email with the recorded session link so that you can watch the session over again at your own leisure. So before we start today, we're going to do an acknowledgement to country. So City Fertility acknowledges the traditional owners and custodians of the country throughout Australia and respect their continuing culture and the contributions they make to the life of these regions. We extend that respect to Aboriginal and Torres Strait Islanders people here today and their elders both past, present and emerging. So without further ado, we're going to turn this all over to Dr. Lisa Harris. Lisa is a fertility specialist here at City Fertility in Brisbane, and she provides specialised care in fertility, gynecology and obstetrics. She's been trained across the major tertiary centres here in Queensland, the Mater, the Royal Women's Hospital in Gold Coast, and she's an examiner for the University of Queensland Medical School and a published researcher. Now, in her spare time, Lisa manages to also raise 3 children and also trains and runs or competes in triathlon. So I'm not sure how you get it to do it all, Lisa. So here we go. Here's Lisa.
Good morning. Thank you for that introduction, Deb, and welcome to everybody from all around the country for joining us this morning on this webinar for fertility. And just like to say, well done for registering. For many of you, I know that this is likely your first step when you've been trying to fall pregnant and not having a lot of luck. So one of the most important things in that journey is taking that step and getting some more information. So I look forward to helping answer some of your questions today. And Debbie will let me know when there's questions coming through. So first of all, I'd like to start with talking a little bit about the definition of female infertility and when you should be starting to consider getting a little bit of help. So fertility is actually more and more common, and it now affects up to 1 in 6 Australian couples. And I'm sure all of you probably know somebody these days who have needed a little bit of help to fall pregnant. There are a number of factors that can contribute to why a couple are having problems falling pregnant. And one of the benefits these days is we have access to so many different ways of investigating fertility, and then also assisted reproductive technologies to help. And so the first part is just finding out a little bit more information about, look, is there any problems there and what can be done to help? The need for fertility treatments is increasing as well. And this is due to a number of factors. One of those is that women are delaying childbearing, and that's due to careers and education. And we are benefits these days of being able to multitask and do many different things. But one of the consequences of that is that some women are leaving it a lot later to have children, and it can get harder as we get a little bit older. Another factor is that our lifestyles and significant weight gain, increase in BMI, is also making it harder to fall pregnant as well. So with 17% of couples experiencing infertility, the important thing is that, you're not alone if you are struggling to conceive. There are many, many couples these days. The experience during COVID, and I understand many of you are out there probably locked down. I heard this morning 50% of Australians are currently in lockdown yet again. COVID has also increased people seeking help with fertility, and I think there's a number of reasons for that. We can't travel so much. COVID's brought us closer to home, and so it's become more and more a focus, having children, having family. So this need for fertility is more and more widespread across our community. So what sorts of things should you be considering? So if you've been trying to fall pregnant for 6 months, if you're over the age of 35, or for 12 months, if you're under the age of 35 and not being successful, then that's the stage that you should be seeking some help. And the first step normally is to see your GP. Another thing to be a little bit cognizant of is if you're not getting regular or you've got absent menstrual periods. So to fall pregnant, there is a few things that you need. You need to have eggs, you need to have sperm, and the two of them need to be able to get together. And if you're not having periods, it's likely that you're not releasing that egg on a regular basis, and it can make it very hard to fall pregnant. If you have any history of pelvic infections, and one of the most common infections we see in the Australian community is something called chlamydia, and this can damage your tubes. So if you've got a history of chlamydia infection, that too can be a reason that it can be difficult to fall pregnant. If you've had 2 or more miscarriages, this is what we call secondary infertility. Then again, there can be some underlying reasons behind that, and it's worth seeking some help to see if you need some assistance with falling pregnant. If you have used an IUD in the past for birth control, now this is more related to infection. IUDs are very, very common these days in the market, and we know that things like the Mirena don't seem to have a negative effect on fertility, but in the past, some of the IUDs could cause some problems. If your partner has had a sterilisation reversal, or if your partner's had a vasectomy, then obviously a little bit of help is going to be needed to get access to the sperm. But sometimes those sterilisation reversals are not as successful as we'd like. So again, some assistance falling pregnant is often necessary. If you're having any difficulties with sexual intercourse, so if there's pain with intercourse, if there's issues with the relationship, that can also affect falling pregnant. And there's many different things that we can look at in regards to that. If you have a history of chronic pelvic pain, now often women with chronic pelvic pain can have an underlying condition such as endometriosis, and those women will often need some help to fall pregnant. So it's worth investigating further. If you have any breast discharge that's a bit abnormal, that's something also to definitely see your GP about, and that can be caused by some underlying hormonal imbalances. I've talked a little bit about history of sexually transmitted diseases such as chlamydia earlier, but another thing to be aware of is excess acne or facial hair. That can be a sign of a hormonal imbalance, along with rapid weight gain or difficulty controlling your weight, or on the other side of that scale, having a low weight and a low body mass index can also affect your fertility. So there's some of the things to be thinking of about yourself as to whether or not any of those resonate with you, and worth investigating a little bit further with your local doctor.
So Lisa,
yeah,
what you're basically saying is, for 6 months of trying if they're over 35 years of age, and 12 months of trying to fall pregnant if they're under 35 years of age. But what about if my partner is, we're only having intercourse twice a month, is that's not going to be considered
active trying? Yeah. So we consider active trying. You need to be having regular unprotected intercourse every 48 hours across your ovulation window. So interestingly, the egg only lives and is able to be fertilized for a period of 24 hours. So if you're ovulating regularly every month, you still only have one 24-hour period where you can possibly fall pregnant. Sperm tend to live for a little bit longer, up to about 76 hours. So we do recommend regular unprotected intercourse every 2 days around that ovulatory window. Now, for most women with regular periods, that ovulatory window is somewhere between days 10 to day 17. But if your periods are a bit longer, it can be a longer window than that, and it can be later. And it can be very difficult to catch that egg.
Thank you.
So So what are some of the causes of infertility? And I've started talking a little bit about these. Ovulation problems is one of the biggest things that we see with women coming to see us for some fertility help. So as we were just talking about, if you're not ovulating regularly, it's very hard to fall pregnant. If you're only getting 2 periods a year, then that ovulation window is just too short, and it doesn't really matter how much intercourse you're having, it's still very hard to fall pregnant. One of the most common reasons for ovulation problems is something called polycystic ovary syndrome. And it also accounts for approximately 15% of women that we see with fertility problems is polycystic ovary syndrome. Now, the symptoms of this are weight gain that you can't control, increased hairiness, increased acne, and women will often be told that they have polycystic ovaries on scan. And we have some other medical criteria that we use to diagnose this condition. But it's important to note that polycystic ovaries on scan is not the same as the syndrome. And generally speaking, most women with polycystic ovaries don't actually have the syndrome, and most of them will fall pregnant without too much trouble. But with polycystic ovary syndrome, again, we know that most of these women will fall pregnant, but they'll usually need some help to do so. Another major reason for problems with fertility is structural problems. So we are talking about the egg and the sperm that need to be able to get together, and fertilization actually occurs inside the fallopian tubes that connect the eggs to the uterus. If these tubes are damaged, it can be impossible to fall pregnant, and that is another one of the major structural problems. There can also be issues with the uterus itself, and you can have some abnormal growths in the uterus, you can have septums in the uterus, and all of these can make it hard for that embryo to implant. So that's another thing we look for. And that looking at the uterus can be done with a simple pelvic ultrasound. Looking at the tubes, we have a couple of different ways of investigating whether tubes are patent. Endometriosis is one of the next most common causes for female infertility. And it is a condition that is being more frequently diagnosed. You may have heard of this before. So it's very common, the symptoms that are mainly associated with endometriosis are heavy, painful periods, pain with intercourse, and a lot of these women will have endometriosis. However, one of the most important symptoms of endometriosis is actually infertility. And in approximately 40% of the women that we see for infertility, they will have endometriosis. And most of them don't have those other typical symptoms of pain or heavy bleeding. They just have infertility as their only symptom. Endometriosis is a little bit harder to diagnose. It does require a laparoscopy, but it is often something we'll consider when we're doing some investigations to try and find some underlying causes as to why someone's not falling pregnant. I mentioned some structural issues with the uterus. Uterine fibroids are one of the other most common causes, and fibroids are just benign muscular tissue that grows within the uterus. So a lot of these are very small and won't actually affect fertility, but every now and again we can find a fibroid that's impinging on the inside of the uterine cavity, and these can all be treated. So if you have a look at this graph on my left, today our focus is on female infertility, but it is important to note that female infertility is the underlying cause in only about 30% of couples who are having trouble. So for the majority, 70%, it's not just female issues. And it's really interesting. Most of the women that I see who come in for a first visit are a little bit nervous, a little bit anxious. It's a difficult time and it's full of emotion when you're trying to fall pregnant. And it's always when you're trying to fall pregnant, it's not happening, that you hear of a friend falling pregnant or a work colleague falling pregnant or someone else. And it can be a really difficult time when it's not happening for you. But it is only 30% where there's a female issue. There's the other 30% is attributed to male factors. And the men too are always quite nervous. Some of them are dragged along fairly unwillingly by their partners, but it is really important to know that it takes two to tango, and it takes both of you to fall pregnant. So we do like to see the men. It's important to investigate them too, as 30% of the time we'll find a male issue. 10% of couples are a little bit unlucky and there's factors on both sides of the relationship that are contributing to why they're not falling pregnant. And then we've got another area which is a little bit tricky. 25% of couples actually, despite the best of our investigations available today, we're not able to find any underlying cause. So
Lisa, with those patients that might be having, they've been trying for 12 months, but nothing's happening, they're best to go and see their GP so we can start to go through all these investigations to see, or should they try before the 12 months? They're getting to say 7, 8 months and, trying and just getting a little bit worried that nothing's happening. Should they go to the GP and start getting some tests?
So I think if anyone has any concerns about that, then there are some basic things that can be done to find out. And increasingly we're seeing couples and women particularly accessing preconception appointments. So appointments just to check that everything's okay. Obviously, if you have any symptoms that you're worried about and you're getting close to that 12 months, that's definitely when it's worth starting that process. And the earlier that you start, often the better it is, and the more it is easier for us to help if we start a little bit earlier. But I think for most couples, 80% will fall pregnant within the first 12 months of trying. Of those couples who don't, that leaves 20%. Most of them will fall pregnant in the second 12 months of trying. So if you're fit and young and healthy and don't have any of those symptoms, sometimes it can just take a little bit longer. But if you've got any concerns, it never hurts to go and see your doctor just to get some basic checkup and some reassurance. And sometimes we will find things in those couples around that 12-month mark. At the end of that 2 years of trying, that leaves about 5% of couples after 2 years of trying just unfortunately can't fall pregnant. And we do know that in that particular group, most of them are going to need help to fall pregnant.
Thank you.
Okay, so I've talked a little bit about some of the major causes for female infertility. And the next part is some of the diagnoses that we actually make as medical professionals. So one of the most common diagnoses is amenorrhea. So amenorrhea is actually the absence of periods. This is something that we can see, and most commonly is caused by extremes of weight, so very low body weight, or at the other end, a very high body mass index, which is your weight-height ratio. Both of those things can cause the absence of periods. Occasionally, we'll also find some hormonal imbalances that cause the absence of periods. And not getting periods comes back to that, what I was talking about before, in that if you're not having periods, then you're not ovulating, and it's impossible to fall pregnant. So that's a really important one to get investigated if your periods are just not coming. And ovulation. So again, we've mentioned the importance of being able to ovulate on a regular basis to falling pregnant. So if your periods are stretching out and they're coming sometimes 28 days, sometimes 45 days, sometimes 60 days, then this points towards an ovulatory disorder. And that's another common diagnosis that we can make. I've already talked a little bit about endometriosis and the importance of some of the signs and symptoms of endometriosis. It's also really important to know if you have a diagnosis of endometriosis, because we do know that it is harder to fall pregnant if you have endometriosis. And also by treating endometriosis with a laparoscopy and removing it, you can actually improve your natural fertility within the first 6 months of trying. So a lot of women are diagnosed in their 20s with endometriosis. And one of the things that their doctors should hopefully be telling them is that, look, if you have endometriosis, it can be a bit harder to fall pregnant. And so we usually advise seeking help earlier if you have that condition. And you may often need more help to fall pregnant. So it's also recommended to try for pregnancy a bit earlier and not leave it too late in your fertility journey. Fibroid tumours, another diagnosis I've mentioned already. Hyperprolactinemia. So this is another condition that's a hormonal condition, and this is very easily diagnosed by a simple blood test and would be one of the fertility investigations that your GP or your fertility specialist would organise very quickly. And prolactin is a hormone that's secreted and it can block your ovulation, and it's also quite easily treated. I have a patient recently who'd come to see me, and she'd been trying to fall pregnant for 3 years and wasn't ovulating properly. And one of the first things we found was that her prolactin was very high. She then had a scan. One of the causes of high prolactin is to have a small tumour on your pituitary gland, but these are generally benign tumours, and by taking some medication, they can fall pregnant. So we were fortunately able to treat her prolactin levels and get them back to normal, and she fell pregnant within normalisation of her prolactin levels within 3 months. So sometimes we'll find some interesting diagnoses when we go looking. Immunological infertility is a much rarer cause, but there are certain medical conditions that can make it harder to fall pregnant, and will often involve an immunologist in that journey. Luteal phase defect is often characterised by just not making a thick enough endometrium, and often this is a progesterone issue. And there's not enough progesterone there. So that's also something that we can help with when it comes to fertility treatment. Occlusion of the tube. So if those tubes are blocked, whether it's been from a history of pelvic inflammatory disease, if you have 2 blocked tubes, or another thing that can cause occlusion is if someone has had an ectopic pregnancy, which is a pregnancy in the tube, and then they've lost their tube as a result of that. So IVF is usually needed in this instance to be able to bypass those tubes and help someone achieve pregnancy. Pelvic inflammatory disease, some women, again, will never know that they've had this condition. We do generally screen everybody for STDs, and one of the hard things for women with pelvic inflammatory disease is that chlamydia is the most common cause, but it's not something that you always have symptoms for. So we screen everybody. If we do find it, we can treat it. And it's really important to be treated. And then we need to have a look at the tubes and make sure that the tubes are okay. Polycystic ovary syndrome. So I've mentioned this a little bit before, right at the start of the talk, but it is one of the common diagnoses that we see. It's also one of the things that we see patients coming in for fertility help who think that they've got this, or they've been told when they were younger that they have this condition, or their GPs have suggested they have it. And it's probably one of the most misdiagnosed conditions that we see, because majority of women don't actually have the full syndrome, and having polycystic ovaries can actually be a good thing for your fertility. So we do pick this up, we do diagnose this, and there are a number of things, lifestyle factors that we need to institute, as well as helping with some treatment and medication if somebody does have the syndrome. But it's also one of those diagnoses that I do find I'm often having to tell women, well, the good news is you have a really good egg count, but you don't have polycystic ovary syndrome. More and more, we're seeing premature ovarian failure. Premature ovarian failure is when the ovaries shut down earlier than would be expected. So the average age for menopause is approximately 50, but in premature ovarian failure, women go through this a lot earlier, and we don't know why this is happening at a slightly higher rate. If someone has ever had any treatment for cancer, that can cause this, but there are certain genetic conditions that can predispose a woman. If you have any history in your family of early menopause, then this is something to watch out for. Now, it's diagnosed typically based on hormonal levels of estrogen and another hormone that we use to stimulate ovaries called follicle stimulating hormone. But one of the tests we use in IVF particularly, but also just in general fertility, is to test something called your anti-Müllerian hormone, or your AMH. And some of you might have heard of the egg timer test, and yeah, the egg timer test is how it's known commonly, and I hear patients asking me about this all the time. So it gives us an idea about what your lifespan to fertility is. I'm seeing more and more women, particularly those who are contemplating delaying fertility due to education, training and careers, checking their AMH at some point, particularly in their late 20s or early 30s, to see where they are. And we've got a graph which gives us typical levels, and we can talk to you about where you sit, and it gives you the ability to plan ahead. And also, if your ovary, your egg count is a lot lower, for a lot of women, they may opt to do something such as try and do egg freezing to preserve their future fertility. And it can really influence the decisions that you make. Again, this is a fairly simple blood test.
Oh, that's what I was just going to ask you, Lisa. Are these just blood tests that you're doing?
That's right. So very simple blood test to check your ovarian reserve. The last one on the diagnosis list that we see quite frequently is uterine or vaginal birth defects. So there are some women who are born with 2 cervixes, with change in the structures in the vagina, change in the structures of the uterus, 2 uteruses. There's lots of different ways in which things don't develop normally. And often it isn't an issue for them until they come time to trying to have a baby. So we do sometimes diagnose these as well. And these are typically diagnosed on either physical examination or a simple pelvic ultrasound.
So Lisa, I'm just going to remind people, if they've got any questions to ask yourself, to please type them into our question and answer section. I know there's a lot of you out there, and I'm quite happy to ask Lisa questions as we go along, and she's quite happy to answer them as well. So please make sure you type your questions in so that we can, help you get them answered today.
Absolutely. Quite happy to do my best to answer any questions you may have. I guess the next step from here, we've talked about some of the things we're looking for and some of the investigations that we would do, is also to talk to you about what are your options. And this can be a little bit scary too. And I think there's a lot of stigma around seeking help for fertility. And these days, I think it is becoming more and more accepted to get a little bit of help. And that's because, unfortunately, there's more and more people needing help, but also fertility treatment, fertility options are improving as well. And we've seen rapid development in particularly the last 5 to 10 years in things like ICSI, which is intracytoplasmic sperm injection, to improve fertility outcomes. And we're also seeing better outcomes again because of genetic testing that can be done. So when it comes to fertility, there's a number of different things that you can find out information about and that may be offered to you. But I think it's really important to note that with fertility, it's really an individualized process, and no 2 couples are really the same. So one of the most important things is to find out, okay, if there's problems here, what can be done to help those particular issues. The treatments that are on offer through City Fertility and myself and my colleagues include the options of donor sperm. So more frequently, we're seeing same-sex couples accessing fertility help to achieve pregnancy. But also there are some situations where there are sperm issues, and we have a big sperm donor bank now available. Another side of that is sometimes, and again, more frequently being taken advantage of, is the ability to access egg donation as well. So obviously these don't apply to everyone. They're quite specific things, but they are options for couples who are really trying to achieve a pregnancy but having a lot of trouble or need other ways to do it. Some of the treatments through fertility practice that we do are as simple as intrauterine insemination or IUI, and that's often done in a doctor's rooms, and it's a fairly straightforward process, a little bit similar to having a pap smear. Obviously, there's in vitro fertilization, and that's a more involved process, and it does take a little bit more time, but it also has quite good rates of success, and those success rates are going up all the time. Intracytoplasmic sperm injection I mentioned before, or ICSI. So in some situations where the sperm is not so good, we can actually pick the good sperm, and our very clever embryologists put it into the egg, and that's what ICSI is. And it's also available for donor sperm. So there are some couples who choose a donor and choose to create embryos using donor sperm. And one of the advantages of using that ICSI process is that then what can happen is embryos can also be stored for future use as well. So there are many couples when they come to see us who are desiring not just one, but maybe two, maybe three children. So one of the other benefits that we have these days is the ability to preserve your future fertility as well by creating embryos that can be used at a later date. Egg freezing and storage is also available, and particularly women who are looking at delaying their pregnancies, are looking at delaying starting a family. Egg freezing is a really good option these days to allow, in most cases, a backup option if there's trouble as you get older. Genetic testing is rapidly expanding, and these days, majority of couples are having preconception screening, genetic counselling, genetic carrier screening prior to achieving a pregnancy. And again, this is a very simple blood test that can be done. And what it does is it checks for things that you may carry and your partner may carry that can be passed on to a child. And we look for medical conditions. So they're not necessarily something you have any family history of because they're quite rare, but when they're conditions that we can't treat and we don't have any cures for. So more and more people are taking up the option of carrier screening. We're talking about things like cystic fibrosis, spinal muscular atrophy, and Fragile X. Now, some of the carrier screens are looking for different genetic issues, and our pediatric colleagues are actually quite on board with this sort of testing being done because some of these conditions are rare, but then unfortunately they do see children that they need to treat with them in their hospitals. And we've now got the option of avoiding these. So if something is picked up that both you and your partner carry, then we have the ability to genetically test an embryo for that condition before it's put back. And this is called pre-implantation genetic testing. So more and more people are taking up the opportunity to do carrier screening.
So these carrier screenings are done prior to them trying to fall pregnant. Is that correct, Lisa?
Yeah, so ideally that's the best time to do it. You can have carrier screening in early pregnancy, but the time frames, it takes about 5 to 6 weeks to come back. And so it's a bit more difficult you can test pregnancies for these conditions, but obviously the stakes are a lot higher once you're already pregnant. And if it's possible to, it's good to avoid these conditions in pregnancy and childbirth. It does make the decisions easier if it's picked up beforehand. And these tests are offered through your GP. And you may have heard of something called Mackenzie's Mission. And this is an initiative which is being undertaken by a couple based out of Victoria to look at the feasibility of trying to get genetic screening done across the board. So Mackenzie's Mission is something that many GPs have registered for.
Lisa,
another thing I did...
Sorry, there's a few questions coming through. I just want to ask this one on freezing eggs. We've been asked a question on what's a good number of eggs to retrieve if you're going to freeze your eggs. Would that be egg dependent?
It is patient dependent, so that does depend quite a bit on your ovarian reserve. So if your ovarian reserve is lower, then at an egg collection, we're likely to get less eggs per egg collection. Now, the ideal numbers, if we're talking about egg freezing and trying to preserve future fertility, we do advise trying to store something like 20 to 30 eggs. Unfortunately, with egg freezing, not every egg that we freeze will thaw well or will go on to create an embryo. So we need more numbers of eggs to be able to preserve future fertility. There are some women, and I guess each IVF cycle, again, individualised, but we're aiming for 10 to 15 eggs as an average. I do have some patients, though, with low egg count as a baseline, and so we'll go to egg collection for only 3 or 4 eggs. On the other end of that scale, we do sometimes have patients who have a very good ovarian reserve and stimulate and get 20 or more eggs in one cycle. It's a delicate balance, and it does really depend. But ideally, if you are freezing eggs, around that 20 to 30 number is what we recommend. So some women will get close to that on one cycle. some women will need a few cycles to be able to achieve that many eggs in storage.
I've also got another question here about carrier screening. Is it for all ages or more common for women over 35 years?
No, so carrier screening is for all ages. So carrier screening is not age dependent at all. So we're not talking about things like Down syndrome. Down syndrome, or trisomy 21, is probably the most common genetic disorder that we pick up in pregnancy and that we see out in the community. But Down syndrome is not something that is inherited. So carrier screening is all about checking what you carry. So, for example, cystic fibrosis is probably the most common of those. And if you are a cystic fibrosis carrier, the only reason that you will have a child with cystic fibrosis is if you happen to partner with someone who also has it. And then you can have it. So it's not an age-dependent test at all. So it's routinely offered to everyone. For our couples who are accessing donor sperm and donor eggs, we recommend routinely screening for what you carry. And most of our sperm donors are also screened for these genetic tests as well. So if you do carry something, and there's up to 175, even to 400 conditions sometimes. So some of the words I can't even pronounce. But if you happen to carry one of these weird and wonderful conditions, you can then check your partner for that, or you can check a donor for that, and then just make sure that you're not going to be passing this condition on. It's also useful, I think, in the long term, for if you find out you carry something, it is also information you can pass on to your children and say, hey, I carry a gene for cystic fibrosis, you may do that too. And then down the track, when they're ready to have children, they too can screen. I do think going forwards that more and more people will have their carrier screening. You only ever need to have it done once. It doesn't change across your lifetime. So it's just a one-off test to have that done.
We'll answer some of these other questions after, Lisa, so I'll let you continue at the moment.
Okay, I just had a couple of other points on the fertility treatment options, and we started to talk a little bit about donor programs. So in instances where we find that a woman's eggs aren't able to achieve pregnancy, we now have access to donor eggs. Donor eggs, and particularly the World Egg Bank, is one of the avenues that we're using to get some eggs to help these families, these women and their partners achieve families. We also have a good donor program for sperm donation as well. Another fertility treatment option is for the investigation and treatment of recurrent miscarriage patients. So there's a number of techniques we have to try and improve fertility in these situations as well. So when should you be seeking help? We've started talking a little bit about this, but just to reiterate, if you're under 35 and you've been trying for 12 months, then highly recommend that it's worth starting with your GP or fertility specialist. Some GPs don't have a huge amount of experience in fertility and are likely to send you straight on. But we're more than happy to see you. It doesn't really bother us whether GPs have done lots of investigations or not, because this is one of the areas we specialise in. So I have some GPs who will send patients to me who literally it's please see Megan for fertility, and that's it. And I have other patients who come through the door with a raft of tests done. So none of us really mind. I guess the biggest thing is taking that step through the door. If you're over 35, we do recommend you seek help within 6 months of trying and not being successful. And that's just because as we get older, it does get a bit more difficult to fall pregnant and difficult to help you fall pregnant. And that's due to unfortunately, no matter what we like to think, I still like to think I'm 21, but I know I'm not. My eyesight tells me that now. But our eggs do get older, doesn't matter how we feel. And sometimes that can affect our egg count and also our egg quality. So if you're struggling over 35 years of age, then seek help a little bit earlier. Other reasons to seek help.
And what about if we're over 40, Lisa?
If you're over 40, Yeah, so it's really important to seek help earlier. So this is probably someone, if you're about to try falling pregnant, that would be ideal to have a preconception appointment for. And look, these days, I think most GPs and even obstetricians like myself are happy to see women for preconception. Just nice to have a check and make sure that there's nothing major. It also gives you the opportunity to have those conversations about carrier screening. And another thing, and they'll often check things like your iron studies, your vitamin D, your liver and kidney function, and some of those basic things it's good to have right before you try. So if you're a little bit older, then seek help. The earlier, the better. Another thing to also remind you all to be on folate. So folate is actually recommended for 3 months prior to conceiving, and this is to reduce the risk of neural tube defects in pregnancy, and it's really important. Other reasons to seek fertility help include if you're a single woman and would like to become a parent using donor sperm. So this is probably one of our biggest growing areas in fertility. And I think I just saw someone yesterday, and she said, you know, often patients have been thinking about this for a long time, and they've talked to their family, they've talked to other people about it, and it's a really big decision. But more and more women are, I guess, taking things into their own hands to achieve parenthood, and we're very supportive in that. So the world is a very complicated place out there, and not everyone meets their ideal partner at the ideal time. So you'll see now, and I've got many friends, I've got particularly career women who've decided to take it into their own hands and become pregnant using donor sperm. So that's definitely something that's worth having a conversation about. If you have irregular menstrual cycles, definitely please seek help. If you have any underlying medical conditions, so I'll see a lot of these women in the obstetric side of my practice for preconception appointments, because it's really important to optimise the management of any other medical condition prior to pregnancy, and in that way it has less effect on pregnancy. And some of the other chronic medical conditions can interfere with your fertility. If you've experienced recurrent miscarriage, please seek help for that. Again, it can be a tricky journey. It can be a really difficult journey if you've been unfortunate to have a number of miscarriages. And once it's 3 miscarriages, we know that about 20% will find something, we'll find a reason there that we can help with. And for the others, sometimes they just need a bit more help. And I guess the other time to seek fertility help is if you notice any of the other signs or symptoms that I've mentioned in the presentation earlier today. But even if you've got questions, it is worth getting a little bit of help. And as I acknowledged before, you know, you've all signed up today, so there's some questions there. So this is probably the first step, and that's one of the biggest things, is to go and start that conversation.
Lisa, there's a question here for, you know, saying basically that there's a lot of different places to go for fertility assistance, and it's quite overwhelming for them. So what sort of questions should they be asking a fertility centre before deciding whether or not they're the right fit for us? Do you think it's this, you know, they need to ask the questions of find a specialist that's right for them, or do you think they should be talking to somebody first to find out the differences in the clinics?
Okay, so that's a very good question. Not one that I see a lot of, obviously, because by the time they get to me, a lot of patients have already made that decision. I think, again, it's very individual. So there are many clinics out there at the moment, and with very similar options and outcome levels in terms of results. But I do think, Deb, as you said at the beginning, one of the most important things is to find someone that you're comfortable with and comfortable talking to and comfortable taking you through that journey, because a fertility journey, it can be a little bit like a merry-go-round or a roller coaster at an amusement park. It can be very up and down. So find someone that you're comfortable with and that you can talk to, and that can help you through that minefield. There are also there's bulk billing options for patients which are offered to those, because obviously the cost of fertility treatment is quite expensive in some cases, and so that is a factor in some decisions. And there are bulk billing clinics that provide that. And through City Fertility, we actually have an arm that does provide a low-cost option as well. Those sort of options are not as well tailored. They're not as individual approaches, but they're still, sometimes they're all some patients will need. So, I mean, budget is obviously a concern in some cases, but I think in all of it, it's really important to find somebody that you feel comfortable with and you can trust.
And I suppose just so that everybody out there is aware, we do have a fertility advice centre number that they can contact, which is 1300 354 354, and they can ring through and ask questions on that, and then the girls will be able to sort of direct them in the right, I suppose, direction for somebody that's going to be good for them. Because sometimes, you know, they'll want a female, sometimes they might have a male partner that's got some issues and he'd be more comfortable with a male doctor. So, you know, around Australia, we've got a whole bunch of different doctors. So, you know, sometimes just even calling through onto those fertility advice lines might be something that can help you make the decision as well. So,
absolutely.
Hopefully that answered that question. I've also got a question on improving egg quality in the late 30s.
That's a tough one. So yeah. That is a tough one. So some of the basic things that you can do to improve egg quality is really factored around lifestyle. So diet and exercise are quite important. You will find lots of various information online about reducing the antioxidants and the free radicals in your diet. Exercise is actually really important. So we do recommend, 30 minutes of exercise at least 3 times a week to improve fertility. And those things can make a difference. There are a couple of supplements that there is some evidence for improving egg quality. So coenzyme Q10, which is available over the counter, or fish oil, is commonly used to try and improve egg quality. It's important to note that the evidence is not brilliant. It's not going to automatically cure an egg quality problem. And there's still a lot of research going on looking at some of the underlying reasons why egg quality is an issue. But at this stage, those investigations have not really resulted in excellent treatments to all of a sudden make eggs that aren't great into fabulous eggs. But it's simple lifestyle things in regards to, not smoking, reduce caffeine, and not consuming too much alcohol, certainly no drugs, and aiming for a healthy weight. So carrying too much weight can actually compromise egg quality. But all of those things every little thing can make a difference.
But we've still got to still be mindful of the fact that in the late 30s, our egg quality is probably going to be diminished over at the fact if we were, in our early 30s. Is that correct?
Absolutely. Unfortunately, we can't fight that process. No. So that's why I guess one of the reasons that we do advise seeking help a bit earlier is because of that issue.
Okay. So hopefully that answers that one. I've got a question about Depo-Provera and fertility after coming off the Depo injection.
Yeah. So Depo can have about a 12-month delay to the return in your fertility when you stop it. So generally after that, though, everyone is okay. And if you've still got ongoing issues, then it really needs to be seen by a gynecologist or fertility specialist. And to be honest, if you're not getting periods back within, that first 6 to 9 months, it's probably worth starting to ask some questions. So I'll often see patients who've come off the pill and not had periods for 6 months, or come off Depo and not had periods. And for some of them, it is just a time factor. We'll get everything working again. But equally, there's a number of women where there's actually some other things going on that we find. So it is commonly accepted that Depo-Provera can delay fertility for 12 months after you come off it. But if there's anything more going on, then really need to look at other things too.
Is it sometimes, Lisa, that the Depo is just covering up something that was pre-existing before they started using it as well? Even like with the pill, they've maybe have already had issues prior to starting the pill, and then they go off the pill and they're not falling pregnant and they think it's the pill, but it's actually that pre-existing condition?
Yeah, absolutely, that can happen. So it's worth asking the questions, particularly after about 6 months, or particularly if you haven't got periods back.
Okay, wonderful. So next question was, what do you think about doing acupuncture with IVF? Is it effective?
Absolutely. So it's not for everybody, and not everybody needs acupuncture to be able to have success with IVF. But there is some evidence to suggest that, particularly in women who are having some trouble and doing multiple IVF cycles, that it can make a difference and improve the outcomes of those cycles. So you'll find most fertility practices are also on board with using treatments such, but acupuncture particularly does have some evidence. Again, it's not going to fix it for everybody. Look, I guess we wish there were magic cures in a lot of these cases, but sometimes every little bit can help. And certainly I've had patients when we've added that in that have achieved success where it wasn't there before, but it's not necessary in all cases.
The next question is about using donor sperm. Is there a low-cost option or bulk billing available? Now, as far as I'm aware, there isn't, and I'm thinking you probably are of the same, that there isn't a low-cost option if you need donor sperm.
No, unfortunately there's not, and I think it's because it's got to be quite carefully controlled. There's limits to the number of children that a donor is allowed to father through the government, quite appropriately, government policies, and so it's quite a regulated area. And I think that's and then there's the costs involved in the sperm preparation and in the storage. So
and I think Medicare comes into play too. I think
and that's right. Medicare will cover some in some instances where there's medical infertility, that it is and using it in an IVF cycle and that type of thing. But yeah, unfortunately, if it's those costs, I think, are a little bit fixed across the board.
But just so you know, with the sperm donors, for the person that asked the question, we do have a donor bank called ADAM, which is ADDAM. You can actually download that app onto your phone or onto your computer, and you can actually look at the donor sperm or the sperm donors that we've got available. So that's just an option for you to have a look at, just in case you're wondering. So, okay.
It's funny you say that, Deb. It's actually changed the way patients come in to see me when they're looking for that, and they've usually already looked at the app before they even walk in the door. So it's a bit interesting, but it's great to have that available to people so that it makes it a little bit more open. I think they can see what's going on. It's good.
That's good. Thanks, Lisa. Now, I've also got a question about endometriosis here. So stage 4 endometriosis and the age of 35. Is there anything I can do to increase my chances of freezing as many eggs as possible in my egg freeze cycle, i.e. nutrition and lifestyle supplements, or, you know?
Yeah, so this is a very difficult one, and obviously that's a difficult situation. So look, there's lots of things to talk about when it comes to severe endometriosis and the age of 35, but basically anything reducing your inflammation from a diet point of view. And I think if you look on the Endometriosis Society, endometriosis.org.au, they actually have some recommendations around diet and reducing inflammation. It's also an area that somewhere another group called the IVF Project look quite carefully at as well. Often in that quite severe endo and age 35, then it is something that I'm hoping that you're already in the care and hands of a fertility specialist, because it can be a bit of a tougher journey. There are also medications and things that we use, and down regulation, and some women need to have their estrogen turned off for a number of months prior to then starting again. And some need as much clearance as they can get surgically to improve all of their outcomes. So it's a bit of a complicated question, and obviously that's a significant issue to have, but certainly some of those options that I've mentioned may be worth looking at. Acupuncture, again, can also be a useful adjunct, but I really, hopefully you've got a good specialist looking after you.
Well, Lisa, is there anything else you want to add to the day?
So I'm just looking, the last little bit that I've got to talk to you about here is, I guess, how do you need a referral to make an appointment with a specialist? So yes, ideally you do need a referral. GPs can provide that referral, and City Fertility website has a referral form you can take along to your GP. So I get referrals direct from GPs, and I get referrals through City Fertility, and then patients go back to their GPs to get that. It's necessary to access your Medicare rebate. So that's the most important thing. Occasionally I do have people come through without them, but often they don't have access to Medicare. So that's probably one of the important ones. And yeah, I guess in summary, with everything that I've spoken about today, I've mentioned from the beginning that fertility is a really individual journey, and it really, your own health can affect your reproductive health. So it's really important to maximize things like lifestyle, exercise, diet, cutting smoking, cutting alcohol, cutting back caffeine when you're trying to fall pregnant. And it's also really important to access help early and see if there's anything that can be done, even sometimes quite simple things that can be found to improve your fertility. And if there's any other questions, I'm quite happy to answer them, and I wish you all the best.
Lisa, there is another question about the endometriosis here. Just about getting pregnant and success rates. Is there any success rates for women? But it's a fairly individualized thing, isn't it? So, you know, it's hard to give a success rate that's going to go across the board for it.
Absolutely. So we always speak in quite general terms when it comes to numbers. So endometriosis does unfortunately make it harder to fall pregnant. It can make it longer to fall pregnant. Often you will need IVF to achieve a pregnancy, and it can involve more cycles than someone that doesn't have endometriosis. But it really depends. There's mild endometriosis, moderate endometriosis, and severe endometriosis, and that spectrum plays a role. And again, if there's other factors that come into play, so every now and again I come across someone who's a bit unlucky and they've got polycystic ovary syndrome and endometriosis, and of course that sort of a patient is going to be harder. Age also makes a difference. So when you're younger, you are less likely to have as big an endometriotic load, and the egg quality is better. So we're likely to be more successful in younger women with endometriosis than we are in older women with endometriosis, because then we're dealing with a number of factors. So it's hard to give you a number, but it's more about, you know, opening that door and getting the help as soon as you can, and in doing those investigations and having somebody try and do their best to get those outcomes for you. And I guess we're all...
I think making sure you go and see a specialist that you're comfortable discussing all this with, because they're going to be the ones that are going to be able to help you with the best success rates.
Yes, definitely.
And one last question before we go. Can you please explain IUI a bit more?
Intrauterine insemination. Okay, so what the details. So intrauterine insemination is basically when the sperm is prepared by the laboratory, and they remove any impurities and concentrate it down and use a special medium, and it's put into a test tube. And then after that, it's timed with your ovulation. So many of us will use just a normal cycle. You have a period, and then after that, you have a scan with your doctor, which checks to see if you're ovulating. And if that follicle is big enough, a lot of us will use a trigger to make you ovulate. And then we do the insemination. And the insemination is quite simple, like a pap smear. You have a speculum that's inserted, a little tube then that just goes in the uterus, and we insert the sperm into the uterus. So success rates are anywhere about 10 to 20%. So when we're talking about conceiving on a natural cycle with a couple having intercourse, it's about 20% chance of success per cycle. So donor insemination has a similar rate. However, it's not for everybody. If you've got other underlying issues, then donor inseminate or just IUI is not going to be a particularly useful adjunct if there's actually other issues going on. But certainly it's a fairly simple procedure to have that done.
So that's wonderful. So thank you, Lisa, for your time today. I'm sure everybody's gotten a lot out of it, and thank you for everybody for coming along. Just letting you know that we, as I said earlier, have clinics all around Australia, not just in Queensland. We are in New South Wales and Victoria as well. So if you are looking for somebody to go and see in those states, as I said, you can just call the 1300 354 354 and the girls there will be able to help you. A reminder also that we'll be sending you an email with the Tips to Boost Fertility Guide so that you've got it, and that will come through on email, and also an email with a link to the session today so that you can watch it at your own convenience. So thank you so much for coming along, and we look forward to catching you in the next webinar. Have a great day.
Thank you.